robotics, and I'm also involved in the Center of Orthopedic Osseointegration here at the Sahlgrenska University Hospital. And I will talk about prosthetic use and mobility with transfemoral osseointegrated amputation prosthesis and results from the OPRA study. You already heard about the treatment protocol, and I will not go into that now. And those of you interested can find in this reference is detailed of the protocol for transfemoral amputees. However, the rehabilitation protocol is for 6 months after the second surgery, which makes the treatment period for about 12 months in the normal case. So what I would like to address today is results from the OPRA study that we started the same year we started to use the OPRA treatment protocol. This study is a prospective clinical investigation on patients with transfemoral amputation treated with OPRA at our hospital. Inclusions have taken quite a lot of time. We started in 1999, and the last patients were included in 2007. So it's been going on for quite a few years now. All the assessments have been performed pre-operative to the first surgery, and then we followed the patients until 2 years after the second surgery, which in fact is 2.5 years since we did the first assessment. As you already heard, the assessments include X-rays, registration of complications, hip range of motion when wearing and not wearing the prosthesis, analysis of energy cost while walking, computerized gait analysis, and self-reported general and specific health-related quality of life assessments. Since I'm a physiotherapist, I focus on the rehabilitation details of this study. And I will focus this presentation on the specific health-related quality of life, prosthetic use, and mobility for the patients included. But first, a little bit of the demographics of patients in the study. So there were 51 patients having 55 implants included in the study. 4 had a bilateral transfemoral amputation and were treated on both sides within the study. That makes the 55 implants. We had a few more males than females. They were around 44 years when included. We had 45 unilateral cases and 6 bilateral cases. However, 2 of the bilateral cases were not treated on both sides within the study. 1 could not be treated at all due to extreme short residual limb and cannot use any prosthesis on that side. The other one were already treated on his first limb before the OPRA study started. So we have treated patients before the OPRA study started as well. Patients in the OPRA study are have their amputation mainly through trauma and tumor, but we had 2 cases with amputation due to arterial emboli. Here they are registered as peripheral vascular disease, and a few other cases. The time between amputation and inclusion to the study was in mean 12.5 years, with a very big range, from less than 1 year up to close to 42 years, which is really a long time using a conventional socket prosthesis. The patients came mostly from Sweden, half of them about, but also quite a number from Norway and Spain, and 1 single patient from UK. So we have the safety and the intention to treat population of 51 patients, a little bit fewer patients in the peer protocol. And then, of course, we have some discontinued patients, like in all other studies. 1 was withdrawn due to problems with the contralateral leg. 1 was lost to follow-up. 1 deceased 6 months after the second surgery due to other reasons. And 3 implants were removed before the 2-year follow-up. The specific health-related quality of life has been assessed using the self-report questionnaire for persons with a transfemoral amputation, named Q-TFA. It gives results in 4 different main scores: the prosthetic use score, the mobility score, the problem score, and the global score. They are all from 0 to 100. The problem score is, however, reversed, which means a lower number is better, a lower figure is better. The mobility score is divided into 3 subscores: the walking aid, the capability, and the walking habit subscore, also from 0 to 100. So if we start to look at the results for the prosthetic use score, this is a combination of number of hours and number of days a week the patient report to normally wear the prosthesis. This is box plots. The blue box is 50% of all values. The bold line is the median value. The small cross is the mean value. And 100 means the prosthesis is used more than 15 hours every day a week. 0 means not using the prosthesis at all. And we had 9 patients not using a prosthesis at all at inclusion. And you can see we have a remarkable change using the prosthesis more at 1 year and also at 2-year follow-up. But we also have some outliers here. So the mean change from baseline to 2 years was an increase in prosthetic use score with 34 score points with a very, very low p-value. If we go to the mobility score, we can see an increase in the mobility score with the same low p-value. The problem score tells about problems when wearing and not wearing the prosthesis. The numbers are lower in those scores because you have to use a prosthesis to be able to answer the questions. And here we have an improvement in, which means less problems. And the global score, which is a summary of the function and the problems and the overall situation as an amputee, also shows an improvement at 2 years follow-up as compared with the preoperative situation. This figure shows the score change for all the scores in the Q-TFA. So here are also the subscores of the mobility score included. And you can see we have the very low p-values all along here, but for 1. And that is the walking habit subscore, which tells us the patient will use walking aid subscore, sorry. They will use walking aids in the same manner they did preoperatively. I've also picked out a few results concerning the energy cost and walking habits for the subgroup of patients having a unilateral transfemoral amputation in this group of patients. And we measured the energy cost with a physiological cost index, which is a simple estimate of energy cost, where you measure the heart rate while resting, while walking in comfortable walking speed. And we have a decrease. I will show you some details very soon. And we have an increase of the self-reported walking habits. I will be back to those. First, the physiological cost index, where you can see we have a decrease already at 1 year and a bigger decrease in the energy cost at 2 years. And it seems like the decrease is due to the lower heart rate while walking, because there is no change in the heart rate at rest. And when you compare the comfortable speed at, what happened? The comfortable speed, it is lower at 1 year, but then it's the same. So the walking speed is not changed. Next figure, this is the self-reported longest walking distance performed outdoors daily or several days a week. And this is for all the patients, also those with bilateral transfemoral amputations. And in preoperative in yellow, you can see about 40% reported that 50 meter was their longest walking distance they performed daily or several days a week. And at follow-up at 2 years, 40% told the same distance was 500 meters, which is quite a difference. The results I have presented here are also confirmed when we look at the general health-related quality of life as assessed by the short form 36 survey. And those of you familiar with the short form 36 I think you agree with me that a score change of 23 is quite a big change in the physical function subscore. And the figure looks a little bit different for the physical component summary score, but that is due to this score have a normalization for a normal population to 50, which makes the figure having a lower increase in the figure. Okay, to the discussion. So there are indeed very few long-term perspective studies in the field of lower limb amputation at all, and certainly within the field of bone-anchored prosthesis, there is no other study. So we can't compare our results with anyone. I'm very happy you start a prospective study now, and I hope we will be able to compare our results in the future. And we very recently finished the 2-year follow-up for the last patients. We did it in May. We had a few of the results to present in Leipzig in May, and the rest of the results we got this summer. So we have hard work to do to analyze those results the coming months and weeks. And 2 years is still a very short period of time, and we continue to follow all our patients. And we have now started to see the first patients for that 10-year follow-up, those that were treated in year 1999. To conclude, the results presented here show clinically significant changes with more prosthetic use, better mobility, increased walking habits, decreased energy cost, less problems, improved overall situation, and an improved general physical health-related quality of life for patients treated with the OPRA when we compare the 2-year follow-up with the baseline figures. Thank you very much, and I hope you will have some time to visit our beautiful seaside the following days. Thank you.